Hi, everyone. My name is Anne-Marie Hayes, and I'm a research associate for the Joplin campus of KCU. Today, I will be introducing our Student-Led Journal Club speaker, student Dr. Miles Turk, who's also an anatomy fellow at KCU. Today, he's going to be talking to us about his cadaveric study that he's been working on as a fellow. So to introduce our speaker, student Dr. Turk is originally from a smaller town north of Minneapolis, Minnesota. He received his undergraduate education from Augsburg University in the heart of Minneapolis, where he played baseball and obtained his bachelor's in chemistry. Between his undergraduate and medical education, he took off a few to serve in the community through an AmeriCorps program called Minnesota Math Corps, where he helped 4th and 5th graders who were falling behind grade level standards solidify their foundational understanding of mathematics. Student Dr. Turk loves medicine because it is where all of the disciplines of science, from physics to sociology and everything in between, intersect to improve the health and well-being of patients. His top interest is surgery, specifically cardiothoracic surgery. Still, he is open to all fields of medicine, as each discipline offers a unique lens through which to view patient care. So with that, the floor is yours, student Dr. Turk.
Well, thank you very much. Thank you to everyone for being here to listen to my research talk. As has been said, I'm Miles. I want to give a shout out to my fellows on the Joplin campus, Kiana and George, and also Dr. Hillard for their contributions to my research. So today we're going to be talking about anatomical variations in the branching pattern of the aortic arch. And so we're going to start today by talking about what the traditional branching of the aortic arch is. From there, I'm going to discuss a few variations that'll be relevant for our talk today, and then hopefully draw some correlations to why these variations are important clinically. So to start, the aorta is the largest blood vessel in the human body, and it's responsible for delivering blood to all the structures throughout our body. There are 3 essential parts to the aorta. So the ascending aorta receives blood from the heart, and it travels around the aortic arch, which is this portion here, and then down the descending aorta, which can be subdivided into the thoracic descending aorta and the abdominal descending aorta. The aortic arch typically has 3 vessels that branch from it, the first being the brachiocephalic trunk, the left common carotid, and the left subclavian artery. So these vessels are incredibly important because they are responsible for supplying blood to the upper extremities, parts of the thoracic wall, the neck, the head, and even up into the brain. Of note, the brachiocephalic trunk is actually the right-sided counterpart to our other 2 vessels that branch off the aorta. So the brachiocephalic trunk subdivides into the right subclavian artery, responsible for supplying the right upper extremity, and then the right common carotid artery supplies structures in the neck, head, and brain. So the typical branching pattern is those 3 vessels, but there have been several variations that have been reported in the literature, the first of which is a common origin for the brachiocephalic trunk and left common carotid artery. So instead of having a distinct location for each of the vessels, the brachiocephalic trunk and the left common carotid artery share a common origin, as the name suggests. So if we look at our example here would be our brachiocephalic trunk. This is our left common carotid artery, and you can see that they're branching from the same location. And then here we have our left subclavian artery. And so in literature, this arch variation in humans has been referred to as a bovine arch, which is actually a misnomer, because if you look at the branching pattern of a bovine arch, their brachiocephalic trunk actually gives rise to all the vessels that supply the structures we just talked about. So here's your right subclavian artery. There's a common origin for the right and left carotid arteries, and then your left subclavian artery. So there's a push in literature to abandon this term for this variation. So today I'll be referring to this variation not as a bovine arch, but as either a common origin or a BCT-LCCA. I'll probably err on the side of common origin just because BCT-LCCA is a mouthful, which is part of the reason why I think this was adopted, is because it's a lot easier to say bovine arch than it is to explain this out every time. The next variation that we'll talk about is an aberrant left vertebral artery. And so the vertebral arteries, both left and right, are branches off of the subclavian arteries. And they're responsible for supplying structures in the, including the spinal cord, brainstem, cerebellum, and even the posterior aspect of the brain. So in this variation, instead of being a branch from the left subclavian artery, the left vertebral artery branches directly from the aortic arch and travels superiorly up into the neck region. So if we follow it here, it's heading up this way, and it's going to enter into the cervical facets, and which are holes in the cervical vertebrae that bring it into those structures I had just mentioned. And then the last variation we're going to talk about today is an aberrant right subclavian artery. So if you remember, I had mentioned that the right subclavian artery is traditionally a branch from the brachiocephalic trunk, but in this variation, the right subclavian artery actually branches directly from the aortic arch, most commonly seen on the left side distal to our left subclavian artery. So if we're looking at this example here, this would be our right common carotid artery. Here's our left common carotid artery, our left subclavian artery, and then the most distal branch coming off is our right subclavian artery. So interestingly, it comes off on this right side, left side, even though it's a right-sided structure. So it travels posteriorly and then travels all the way into the right upper extremity. And its course typically takes it behind. So if we're looking here where my laser pointer is, those structures would be most anteriorly would be the trachea, and then behind that would be the esophagus. So this vessel is traveling typically behind the esophagus, but in some cases it can split the trachea and the esophagus and travel between those. So those are three of the variations that will be useful for our talk today. There are other variations that exist. Of note, there's a common trunk for both the left and right common carotid arteries, and then sometimes the aortic arch can be flipped, and instead of traveling down the left side of the body, it actually is on the right side of the body. So generally, these variations are considered to be asymptomatic, but these variations have been associated with several disease states, including aneurysm, which is a dilation in the wall of the vessel. And it's weakly associated in the literature with aneurysms, but there is a stronger association with variations and type B aortic dissection. So what aortic dissection is when the layers of the wall of a vessel separate, which create a false lumen, which we can see here. And this false lumen allows blood to enter in. And specifically a type B aortic dissection is when this occurs beyond the branching of our major vessels, which are shown up here. Variations have also been associated with congenital heart defects, and specifically for our aberrant right subclavian artery, you can see dysphagia and dyspnea, which are trouble swallowing and trouble breathing, which makes sense if you think about the course that this is taking. If it's traveling between or behind the esophagus and the trachea, if for any reason that vessel compresses those structures, you're going to have these clinical symptoms. So as I mentioned, they're asymptomatic, which leads many of these variations to be incidental findings in clinical practice, and therefore their prevalence may be underreported and perhaps understudied. So detailed mapping of the vessel location and orientation could provide practical knowledge for both surgical and radiologic intervention, as well as the development of prosthetics for aortic arch repair. So the aim of my study was to assess the prevalence of the aortic arch variations in our donor population here at KCU, and then provide more detailed mapping of the vessel orientation and characteristics for each of our variations. So how did I do that? So I started by dissecting the thoracic cavities of 48 formalin-emballed cadavers on both the Kansas City and Joplin campuses. I did initial identification of the branching pattern as either the traditional three-vessel pattern or by the specific variation that was observed. And then after my dissection, I took photos of each of the arches from various angles for future measurements using a software called ImageJ, which allows you to set a scale and then take detailed, precise measurements of images. So from there, our traditional 3-vessel arches were subclassified as either type 1, type 2, or type 3. And this was based on the vertical distance of the origin of the brachiocephalic trunk below the top of the arch. So to do that, we needed the diameter of the left common carotid artery, because that's what we used as a reference for how far below the origin of our brachiocephalic trunk was. So a type 1 arch is when the brachiocephalic trunk branches less than 1 diameter of the left common carotid artery below the top of the arch. And we have an example of that here. A type 2 is when the origin of the brachiocephalic trunk is between 1 and 2 diameters of the left common carotid artery. And then finally, a type 3 arch is anything greater than 2 diameters of the left common carotid artery. And so the reason for this subclassification is in my literature review, I found that a few authors claimed that type 2 and especially type 3 arches behave more like an aortic arch variation, specifically in regards to that type B aortic dissection that we talked about before. So then from there, with the images that I took, I performed measurements included in this figure, and I'll kind of walk through what I did there. So for each of the vessels, I took both proximal and distal diameters of the vessels. And this was done within 1 centimeter of its origin for the proximal measurement. And then the distal measurement was at 30 millimeters or 3 centimeters from its origin. The only vessel that I couldn't get to 30 millimeters every time was the brachiocephalic trunk. And that was because often the brachiocephalic trunk split into its right subclavian and right common carotid artery, shorter than 30 millimeters. So for those vessels, I just went 5 millimeters proximal to the branch point and took the measurement there. Also, I measured the distance between each of the vessels, so the distance between the brachiocephalic trunk and the left common carotid artery, the left common carotid artery and the left subclavian artery, and then for any of those aberrant vessels that I found as well. And then for each arch, I measured the distance from the start of the arch to the end of the arch, so the start of the brachiocephalic trunk to whatever vessel was the last vessel to branch, which most commonly was the left subclavian, so I measured that distance. And then lastly, I took the angle between the brachiocephalic trunk and left common carotid artery. So for my results and discussion, I'm going to start by talking about the prevalence of each arch type that we found. I'm going to specifically focus on a couple of the variants, specifically the common origin and then the aberrant left vertebral artery. So 60% of our donors had the traditional 3-vessel pattern. And if you compare that to what's been reported in literature, that's slightly below the range that's been provided. And if you look down this table, there is a wide range of what's been reported for each of these variations and subtypes. So I think that just kind of drives home the point that there isn't an accepted range for the prevalence of these variations, and it kind of solidifies the need to further examine these variations. So then within our type 3, you can see the distribution of the type 1, 2, and 3. And then 17 of our donors had a common origin for the brachiocephalic trunk and left common carotid artery. 4 of our donors had a direct left vertebral artery. And then 1 of our donors did have an aberrant right subclavian artery. And for anyone doing quick math, 60, 35, 8, and 2 does not add up to 100. And the reason for that is 3 of our donors contained both a common origin for the brachiocephalic trunk and a direct left vertebral artery. So if we break it up using that distribution, 30% of our donors had a common origin, 6% showed both a common origin and a direct left vertebral artery. 2% or 1 donor had a single left vertebral artery isolated, and then 1 aberrant right subclavian artery. And so what we have here is our donor population had a slightly higher variation rate than had been reported in literature. So looking at our donor population, the average age of the sample I used was 74.5 years old. We had 28 males and 20 female cadavers. And then you can see the height and weight distribution for each of the groups, and you can see the distribution of male and female as well. So variations were slightly more common in our female group at 55%, and than our male group, which was 32% of our male donors. But there was no correlation between sex, age, weight, and height was observed for any specific variation or subtype. So this figure should look familiar. This is the same figure I had in our method section. So as you can imagine, all these measurements generated a wealth of data, and a lot of which didn't show any significant differences between the groups. That's not to say that that's not important, because I found it very interesting that even though we have different branching of vessels, a lot of the measurements, including like diameter or length of the arch, were the same among the groups. But rather than walk you through all those figures and data, just to say the same thing over and over, that we didn't find any statistical significance, I'm going to focus on some of the findings that we did find. So the first interesting finding we found for the common origin group was there were two subclassifications that could be identified. The first, which we're denoting as type A, was the brachiocephalic trunk and left common carotid artery shared a symmetrical trunk before splitting to their respective distributions. And then type B was when the left common carotid artery, rather than sharing a trunk, was more of a branch directly from the brachiocephalic trunk. So if we look at our examples here you can see that there's more of a symmetrical trunk, and then our brachiocephalic trunk and left common carotid artery are splitting to supply their respective areas. Versus here here's our brachiocephalic trunk, and branching directly from it is our left common carotid artery. So for these subclassifications, it was about 50-50 for each of the subtypes. We had 7 type A's, which is that common trunk, and 8 type B's. And then 2 of our arches were excluded from our measurements just because of the condition of the arches following the dissection. They were just, as I was dissecting, the arches were kind of falling apart. And I could tell that they were common origin variant, but the pictures just weren't high enough quality to take measurements from. And so what I want to draw your attention to here is that although we did see qualitative differences between our type A and our type B subtypes for this group, we didn't find any statistically significant quantitative measurements. The one measurement I did expect to be different was the measurement of the left side of the trunk. So what I did for each of these trunks is I measured the right side from the base of the trunk to the branch of the brachiocephalic trunk. I measured the distance from the center of the trunk to the branch point, and then on the left side from the base of the trunk to the branch of the left common carotid artery. And if we look at our examples over here, you can see that we have a more symmetrical trunk here versus here. The left side is shorter because of the orientation of the branch for this. So I expected this measurement here, the left side of the trunk, to show some sort of difference. And we accept statistical significance at 0.05, which is kind of arbitrarily chosen. So this measurement was actually 0.07, so just outside of statistical significance. But I imagine as I increase my sample size, because roughly 7-8 cadavers in each group isn't a strong enough power. So as I increase sample size, I do imagine that this would reach statistical significance. And I'll explain how I plan on increasing sample size in a little bit. So from these qualitative measurements, it still has importance for a surgeon preparing for aortic arch repair, understanding that there are multiple variations for this subtype. can help them plan their approach, specifically for transendovascular aortic arch repair. The next group we're going to talk about is the aberrant left vertebral artery. And so this variation is less common than some of the other variations, but it's still a very important variation because the left vertebral artery, or both vertebral arteries, are responsible for supplying incredibly important structures in the neurologic structures. So damage to these vessels could have lasting impacts for patients. So understanding where and how they branch and that this variation does exist is really important for surgeons preparing for neck or thoracic surgeries. So, as I mentioned before, 3 of the 4 samples had both our left vertebral artery. I'll go back to this one. Had both the aberrant left vertebral artery, and you can see these 3 also have the common origin for the brachiocephalic trunk and left common carotid artery. Interestingly, all 3 of those samples, so if we're looking over here, this is 1, 2, 3, 4. All 3 of the arches that had both variations were male. I thought that was interesting. And then the left vertebral artery, in all cases, branched proximal or before our left subclavian artery and was closer to that left subclavian artery in all the samples. Which, if you think about the normal branching from this, it is typically a branch from the left subclavian artery. So my thought is whatever happens developmentally that causes this to branch from the aortic arch rather than from the left subclavian artery keeps it in close proximity to that vessel. Another interesting finding was that for all the arches for the left vertebral artery group, the average distance between the left common carotid and left subclavian artery was greater when compared to all the other subtypes except for the type A brachiocephalic trunk. So the measurement I'm talking about is from this vessel to this vessel, this measurement right here. So there was a greater average distance with our left vertebral artery when compared to all the other subtypes, which may or may not have clinical implication. I mean, we only have 4 samples in the study of this variation, but it could potentially become a marker for, let's say, you're preparing for a neck surgery and you get radiologic imaging that shows a greater distance between your left common carotid and your left subclavian artery. That might be an indication just to double check to make sure that there isn't an aberrant left vertebral artery, just because it is such an important artery, and if this were compromised during a surgery, it could have severe lasting impacts for patients. So what I want you to take away from my research talk today is that variations in the aortic arch may be more common than is currently reported in literature. However, we have a limited sample size in my study, so it's hard to make assessments on a population level. So where I plan to go from here is increasing my sample size through a CT database that has thousands of CT images of recently deceased individuals who had head-to-toe CT scans. And then we have a program called Dragonfly that allows you to make 3-dimensional models from CT data. So I plan on doing a very similar study to what I've done here, just with a much greater sample size. And then also that association I talked about between type B aortic dissection, I'm very interested in looking at this as well. And so I plan on adding in vessel characteristics of the descending thoracic aorta, including luminal diameter, vessel diameter, and wall thickness, just to see if there's any associations for the variations, to see if we can't shed a little light on why this association exists. So some of the limitations, one of which I've already talked about today, is the sample size. One of the points that drove this home for me was if I had just looked at the Joplin campus or just looked at the Kansas City campus, my results would have been strikingly different. If I just used the Joplin campus, it would have looked like the only variations we had in our donor population were the common origin for the brachiocephalic trunk and left common carotid artery. it wasn't until I went up to Kansas City that I started to find a lot of the other variations that I talked about today. Being a cadaveric study, we were kind of limited by how well the arch was preserved. Some of the arches were in better condition than the other, and a lot of times the vessels for the arch were compressed and flattened, so it was more difficult to get measurements from those. And in a living, healthy individual, your vessel's diameter changed size with each heartbeat. So it's more like taking a snapshot rather than actually seeing functionally how these vessels are in the body. And then lastly, we're very limited with the demographic data that we get for our donors. We do get some information about medical history, but a lot of that information is incomplete or inaccurate. And then we also don't get any information about ethnicity or past medical history, so some of the things that they dealt with. So in the adding CT data, a lot of that information will be filled in. Then we can start to look at our specific variations, more common in certain populations than others. So that's kind of where we're going to go next. I want to give a special thank you to all the donors. Their selfless sacrifice made not only my research possible, but all the research of the fellows here at KCU. And more importantly, it enhanced the education of our first year students. So our sincere gratitude to all of them. Here are my references. And thank you everyone for listening. I'll open it up for questions.
Awesome. Thank you so much, student Dr. Turk. Great presentation. Well done. As he just said, if anybody has any questions, feel free to raise your hand in Zoom, or if you can't talk, you can type it in the chat and I will read it out loud so that it's in the recording. Any questions, comments? Dr. Wolf?
So I actually thought of three things as you were talking here. So the first had to do with, to what extent does this run in families, or is this an epigenetic phenomenon that happens during embryology?
That's definitely an interesting question. It's hard to say, especially because we're getting a snapshot and we have limited information about these individuals. I will say that in some of the papers I've read, it may have to do with genetics, but it's more about which portions of the vessels regress as you're going through embryologically. So I would guess it's a nice mixture of both, that the nature and the nurture. You know, your environment plus your genetics are gonna affect how everything develops in your body.
The other thing I thought of was, do they ever transplant that aberrant right subclavian vessel?
From what I've seen, it's typically left alone, just because the majority of those, like, you can see dysphagia and dyspnea with those variations, but the majority are still asymptomatic. So I would imagine if it's causing lasting symptoms, perhaps it could be moved to that right side, but I would imagine that would also have, you know, complications from that as well, rather than, you know, a little bit difficulty swallowing or breathing.
And then the last thing I thought of had to do with that fourth blood vessel. I was looking, I didn't know what the Dacron or, you know, the prosthetics look like, but the ones that I see, it looks like they're prepared for having three branches coming off. So I'm assuming that fourth branch is what really screws things up, because otherwise, if you just got three tubes and three blood vessels, you know, you don't have to necessarily attach them back in the same place as long as they're attached.
Mm-hmm. Yeah, a few of the articles that I read that were talking about, especially for aortic arch repair with prosthetic, is saying that if there is that fourth vessel, a lot of times they'll attach it to one of the other vessels, they'll basically make the brachiocephalic trunk again for that right aberrant right subclavian artery. So they'd put that with the right common carotid artery, that fourth vessel. So kind of making it back into having three vessels, if that makes sense.
Great, thank you.
Yeah, thanks for the questions.
I have a small question. So articles claim that there is association between certain heart diseases and variations of the aortic arch. Did you see some correlation?
I did not see any of the associated congenital heart defects. I think on both campuses, I can't confirm with KC, but on our campus, the only congenital heart defect was a patent foraminal valley, which is for anyone who doesn't know what that is, that's the connection between the atria. There's a hole that can sometimes be left between them. So one of our donors in Joplin had that, but they also just had a normal arch variation. They didn't have one of our variations. So the most common congenital heart defect that I saw with, or in the literature with variations, was bicuspid aortic valves. And so I think that had to do a lot with like Marfan syndrome. So I think individuals with Marfan have a slightly higher prevalence of variations, and that's where the bicuspid aortic valve comes from.
Okay, thank you. So all arches were left arches, yes?
Yep. I didn't find any right arches. I was secretly hoping that we would have at least one, just because that'd be very interesting to see, but unfortunately not.
Thank you.
Thank
I don't know in the history of Joplin, or since I've worked at KCU, that we've ever had a right arch.
Oh, really?
Yeah.
One of the posters at AAA, they had a right arch, so I sat and talked with that individual for a good while about that. It was interesting.
Tony might remember if we've had any prior that I don't recall, but I don't know that we've had any since 2017. So
I
It's
have not seen one.
1%, so we have to have hundreds. Yes.
I have a question.
Yes, Kiana.
So aside from not knowing the demographics of like the cadavers and stuff, what do you think is the most significant limitation of the embalming process, like that it had on your measurements?
I'd say probably I'm not sure how it affects the aortic arch, but I know, so the aortic arch it's an elastic vessel. So with every heartbeat, it expands and contracts, expands and contracts. And so in the embalming process, it gets fixed at a certain diameter. So it doesn't have that ability to expand and contract like a normal arch would. And I imagine it's the same for the vessels branching off the arch too. There's going to be some natural distribution in the vessel diameter based on how it was fixed and where it was at during that fixing process, if that makes sense.
Any other questions, comments? I do have a question. I did have to get up at one point, so sorry if you answered this. But how do you think these variations will affect like heart surgery? I know you mentioned cardiothoracic being like a personal interest for you, but how do you think these variations will affect like cardiothoracic surgery and what physicians should know?
I think an understanding that they exist is incredibly important, especially if you're going into the thoracic cavity and working around the arch. If you don't know that, you could have the left vertebral artery branching directly from, or the right subclavian could be traveling behind the esophagus and the trachea, it's much more likely that you'd injure one of those vessels than someone who has at least that knowledge, and as they start to work in the area, say, I'm looking out for this, and I can prepare for that. And also for the development of future prosthetics, knowing how prevalent some of these variations are could start to lead to different ways of developing prosthetics, if that makes sense.
Awesome.
Thank you.
Last chance, questions, comments? Well, if not, thank you so much, student Dr. Turk. Thank you everybody for being here today. Wonderful presentation. Well done.
Yeah, thank you. Thank you everyone for coming.